Welcome back to the Masterclass, everyone. Today, we're unpacking Major Diagnostic Category 14, focusing entirely on pregnancy, childbirth, and the puerperium. Now, if you were with us for Part 102, you probably remember we tackled the surgical DRG logic for gynecological surgeries. Well, today, we're shifting our focus over to the maternal health diagnostic category. And let me tell you, it's got its own incredibly unique, highly specific set of rules that we really need to master.
But first, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Okay, here's our agenda for today. First, we'll do an MDC-14 obstetrics overview. Second, key obstetric root operations. Third, coding a clinical case study. Fourth, CDI validation and compliance. And we'll wrap up with a summary and a quick teaser for Part 104.
Section 1. MDC-14 Obstetrics Overview. Let's get right into it.
So the absolute crucial point to grasp right out of the gate is that in ICD-10 PCS, obstetrics hospital procedures always begin with Section 1 and Body System 0. This uniquely targets the pregnancy system. And what's really vital to understand here is that you're not just coding procedures on the mother, you're actually coding procedures performed on the products of conception. We're talking about the zygote, the embryo, the fetus, the amnion, the umbilical cord, and the placenta. And ultimately, whether a case falls into a medical DRG or a surgical DRG completely depends on whether a major operating room procedure was performed on these specific body parts.
Now you might be wondering, how exact do we need to be? Well, incredibly exact. Notice how precise we must be with our gestational timelines. Words matter immensely here. A preterm delivery is strictly less than 37 weeks. Term is 37 to 40 weeks. Post-term stretches from 40.1 to 42 weeks. If your provider documents postpartum, that specifically means the 6 weeks right after delivery, while neonate refers to the baby from 0 to 28 days old. Honestly, abstracting an incorrect gestational week or mixing up these definitions is a fast track to a DRG mismatch and immediate payer denials. We definitely want to avoid that.
Section 2. Key obstetric root operations.
Okay, so if the physician simply assists a spontaneous vaginal delivery without using any specialized instruments, our root operation is strictly delivery. This translates to a character E in your PCS code. And remember, it applies exclusively to manually assisted natural vaginal deliveries. But the moment a device like forceps or a vacuum gets introduced to assist the delivery or a C-section is performed, the root operation fundamentally shifts. We are no longer coding a delivery, we're now coding an extraction, which is character D. Extraction literally means pulling or stripping out the products of conception, and it requires specific qualifiers based on the exact tools or incisions used.
Now, for medical necessity terminations, the root operation is abortion, represented by the character A. But you can't just stop there. We must abstract exactly what method was used. Was it a mechanical means, like a vacuum aspiration? Or did they use an abortifacient device like a laminaria stick? That little detail completely changes your sixth character device value, so keep an eye out for it.
I want to pause here for a second and challenge you with a scenario that coders constantly mix up when reviewing MDC-14 charts. What is the fundamental coding difference between labor induction and labor augmentation? Take a second to think about how these actually present in a clinical chart.
The best way to think about it is this brilliant little metaphor. Induction is the spark that starts the fire, while augmentation is adding fuel to a fire that's already burning. Induction means the provider is using agents like Pitocin or Cervidil to start labor before it even begins spontaneously. Augmentation, on the other hand, means the patient is already in active labor, but those contractions need a boost to progress the delivery. Please do not confuse the two.
Section 3. Coding a clinical case study.
Let's look at a real-world scenario. Here we have a high-acuity patient. She's 29 at 40 weeks, which we now know is full term, right? She comes in for a planned induction due to mild pregnancy-induced hypertension, but things escalate quickly. We see profound fetal bradycardia lasting 11 minutes, which forces the clinical team to completely abandon the vaginal delivery. This results in an emergency classical cesarean delivery. And to complicate matters even further, she suffers a uterine rupture and requires a whole blood transfusion. So her admission just wildly pivoted from a standard medical MS-DRG trajectory to a highly complex surgical one.
So for this surgical intervention, we have to build our 7-character code methodically. 1 for obstetrics, 0 for pregnancy. Because it's a C-section, the root operation is D for extraction, targeting 0, the products of conception. The approach is 0 for open and Z for no device. Now you might initially be tempted to use the qualifier 1 for a low cervical incision, as that's very common. However, as skilled coders, we always read the operative report closely. Our case study explicitly stated it was a classical cesarean delivery. Therefore, we absolutely must adjust that 7th character qualifier to match the exact incision type documented by the surgeon. Attention to detail is literally everything here.
Section 4. CDI Validation and Compliance.
You know, you are quite literally the final line of defense for revenue integrity. As a general rule, you absolutely must trigger a query whenever obstetric documentation is incomplete, conflicting, ambiguous, or lacks clear present-on-admission status. If a provider documents a condition without supporting clinical evidence, or if the diagnosis is just too vague to capture the true severity of the mother's illness, you have to query. No exceptions.
The CDI workflow is a really precise sequence. First, we review the chart concurrently to identify gaps. Next, we generate a compliant query, meaning it is non-leading and based purely on the evidence. Third, the provider reviews our options, clarifies the diagnosis, and authenticates the chart. And finally, the coder updates the diagnosis, which ultimately updates the IPDRG for the ethical optimization of the facility's reimbursement.
But remember, your queries absolutely cannot lead the physician to a higher-paying diagnosis. They must provide clinical choices backed purely by evidence in the chart. For example, you can't just ask, "Do you agree the patient has septic shock because her blood pressure is low?" That is leading. Instead, you must point to the clinical indicators, like an elevated lactate or a sudden drop in creatinine, and ask the provider to clarify the specific diagnosis based purely on those objective findings.
Let's look at a prime example in the OB world. Say a localized infection like chorioamnionitis escalates. We need to look for specific systemic indicators. Is the temperature over 101? Is the respiratory rate over 20? Is the heart rate over 90? Are the white blood cells elevated above 12,000? If you see these indicators, but the provider only wrote infection, you must compliantly query for sepsis. Why? Because capturing sepsis acts as a major complication, or MCC, which drastically shifts the MSDRG weight.
And if sepsis actually is confirmed by the physician, sequencing is strictly governed by whether it was present on admission or arose as a postoperative complication. If it's present on admission, sepsis is your principal diagnosis. But if the sepsis developed from a postoperative complication, say an infected C-section wound, the complication code goes first, followed by sepsis as a secondary diagnosis. Mastering these sequencing guidelines is exactly what separates good coders from truly great ones.
Section 5. Summary and our teaser for the next explainer.
All right, let's quickly summarize everything we've covered today. Mastering MDC-14 requires you to differentiate your root operations perfectly. You've got to know exactly when a delivery becomes an extraction. You need to know the difference between starting a fire with induction versus fueling it with augmentation. And always partner with your CDI team to ensure every complication, like an unexpected maternal hemorrhage or sepsis, is clinically validated in the chart.
Next time, we're going to expand on this foundation and jump entirely into the surgical DRG logic for complex deliveries, exploring exactly how various high-acuity interventions impact hospital reimbursement in Part 104. You won't want to miss it.
Until then, I want to leave you with a provocative question to bring back to your teams. Ask yourself, does your current facility's documentation actually hold up to this level of scrutiny? Are you clearly distinguishing between spontaneous deliveries and extractions, or are you risking compliance audits and leaving hard-earned revenue on the table? Definitely something to think about.
If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Thanks so much for tuning in. Keep studying hard, and I'll see you in the next explainer.